We welcome Dr. Jim Martin in the second lecture, Sport and Asthma.
Thank you very much. So we actually have phenotypes of presentation. We have presentations by the elderly and presentations by the young. So we're back to the elderly. So my topic is asthma and sport, but I've broadened it to asthma and exercise. Now, the possible associations of asthma with sport are the following. Asthmatics may in fact engage in sport without any symptoms whatever. They may have dyspnea on exertion. They may have dyspnea at the beginning of exertion, but they may actually recover in the course of the physical activity. They may have dyspnea and wheezing exclusively post-exercise. In some cases, the practice of sport may actually be associated with an overall worsening of asthma. And of course, there's the question then, are there actually benefits of exercise for asthma? First of all, the physiological responses to exercise, which we know well, and there was a very nice lecture on exercise testing. But you can see here that obviously the heart rate increases linearly with increasing workload or oxygen consumption, and ventilation increases also in this curvilinear manner. Now, usually, I think it's important to note that the heart rate increases from, let's say, 70 to 170, but ventilation may increase from 5 liters a minute to 150 liters a minute. So there's an enormous increase in minute ventilation and stresses that this produces for the respiratory system. The maximum heart rate is predicted in this way, and maximum ventilation is predicted from the FEV1, usually multiplying it by 35. So clearly, under normal circumstances, the heart rate usually reaches a maximum. This is the predicted, but it usually reaches the maximum in a healthy, fit individual on exercise. Ventilation doesn't achieve this particular number because in fact you cannot sustain this ventilation for any length of time. This is the predicted maximal available ventilation, but we do not in fact usually use all of the available ventilation. So the determinants of maximum exercise are obviously cardiac output and oxygen delivery to the tissues, and its utilization are normally the limit to maximal exercise. However, ventilation also reaches a level where it is probably close to the maximal that can be sustained. So these are fairly well matched, in fact. And of course, it's important to consider peripheral muscle conditioning. So if one has poor condition of the muscles, one will not exercise very much. So ventilation obviously is given by tidal volume and frequency, and we increase tidal volume usually by obviously increasing the end inspiratory volume, so we breathe in more, but we also breathe out slightly more and we go below the normal functional residual capacity. So this is a good strategy which is not necessarily available to an asthmatic. And the reason for that is that if we look here at the maximum flow volume curve in the asthmatic, this is inspiration and this is expiration, and if we look at tidal breathing here at rest, obviously it's quite a distance away from the maximum flow volume curve. But when the individual starts to exercise and flow and volume increase, eventually the flow and expiration will reach the maximum flow and the individual will be flow limited. Now, of course, as exercise intensity proceeds, and here we're looking at different levels of ventilation from 55, 74, 81 liters per minute, 94 liters per minute. What happens is that in order to recruit the increase in tidal volume, the subject will obviously breathe in more, but will also not succeed in returning to a normal functional residual capacity. So there is progressive hyperinflation that takes place, which has significant consequences for the mechanics of breathing and for the way the person feels when they're exercising. And this is shown a little bit more detail here, and what I'm showing you on the left-hand side is the volume of the rib cage, and this is the volume of the abdomen. In other words, the position of both of these structures. So normally, if we were to take a breath in all the way up to total lung capacity, and if we were to look at the relationship between rib cage volume and the volume of the abdomen, when all of the muscles were perfectly relaxed, in other words, you occlude the mouthpiece, let's say, and you relax all your muscles, the relationship between rib cage and abdomen would follow this particular dotted line. And usually we breathe around that when we're breathing quietly. Now, during exercise, you can see that the abdominal volume gets less. So we move over this way, and the rib cage volume follows this particular trajectory up and down. So the fact that abdominal volume falls means that we push in the abdomen by recruiting expiratory muscles, and this has the advantage of adjusting the length of the diaphragm in particular. This is the relationship between muscle force and the length of the diaphragm, or any skeletal muscle. There's an optimal range for force generation, and if the muscle becomes very short, the force falls off. If it becomes very long, obviously, the force falls off as well. So we have to really work in a range which allows the muscles to generate proper force. And if you were to have an asthma attack and be up here, for example, with a very, very short diaphragm, this would be a significant disadvantage, or a very short intercostal muscles. So that the phenomenon of hyperinflation very much disadvantages the subject because it increases the work, but it also disadvantages the skeletal muscles, the respiratory muscles, from the point of view of displacing them away from their appropriate operating lengths. So this is what we should do on exercise, but we're more likely to move up in this general direction if we are having a concomitant episode of asthma plus exercise. Now, it was mentioned in the previous talk that children often have symptoms of asthma when they exercise. And this is in fact a study of athletes that were taken out and run. So they were challenged at a high level of exercise, and their peak expiratory flow was measured following the exercise. Now you can see on average this is the sort of 10% line for the change in the peak expiratory flow. Most of the subjects did not drop their peak flow more than 10%, but there were some that did. So that there are in fact individuals that are asymptomatic that will develop post-exercise bronchospasm, which when it becomes clinically significant, we call exercise-induced asthma. Some subjects also, of course, will have no change, and others will actually have some bronchodilation or increase in peak flow following exercise. So this particular phenomenon, which we call exercise-induced asthma, has a tendency to overlap with normal physiological processes, and it's hard to call it a pathology under all circumstances. Of course, if a patient comes into your office complaining, they're asking for treatment, therefore in a sense it defines itself as a pathology, but otherwise it is, when it's an isolated phenomenon, it probably is quasi-physiological, let's say. Now the relationship between the intensity of exercise and the conditions of the inspired air, these two things will in fact determine the likelihood of exercise-induced bronchospasm. So if, for example, you walk, you jog, or you run, you will have a change in FEV1 that will increase as exercise intensity increases. And if you do this in winter, you're more likely to have extreme bronchospasm than if you do it in the summer, or if you inhale air that is humid and at body temperature. If you do that, you can completely abrogate the response, the bronchoconstriction, to the exercise challenge or to the increase in ventilation. Now, exercise-induced asthma is actually typically post-exercise airway constriction, occurring between 5 and 15 minutes post-exercise usually. It often resolves fairly quickly. It may do so within 30 minutes to an hour. And it's very unusual to have a late response to exercise, although there are some individuals, when they engage in very intense exercise, may have symptoms that actually are fairly prolonged. And I've had some athletes, high-level athletes, that experienced that they had, after intense exercise, had symptoms of expectoration, sputum that lasted for days to weeks. Now, what about dyspnea on exertion? So most of the asthmatics will complain not that they have typical post-exercise symptoms, but will complain about dyspnea on exertion. So the question is this because they're already bronchoconstricted when they exercise, or can you also develop bronchoconstriction during exercise? There's not a lot of literature on this, but this was a paper showing that in fact, if we look at the left here first, what the patient or the subject has done is to exercise at about 80% of their maximum for a period of about 6 minutes in this case, or 5 to 6 minutes. Following that intense exercise, there was a fall in the FEV1 by about from 3.3 down to 2.4 liters. Now, in the same subject, if they continued to exercise beyond this point, so they continued exercising beyond this point, eventually there actually was a fall in the FEV1 that occurred during the exercise, although the development of the bronchoconstriction seems to be a little bit delayed over what happens if you have a short burst of intense exercise and then you stop. So it is possible, but not that often studied, obviously for convenience. It's easier to measure the FEV1 when the person stops and can do the maneuver. But if you measure it during exercise, you will find that it will go down. And in fact, if you look at blood gases, in this case saturation, and over here we have the arterial oxygenation. So we have a lot of different subjects here. We have subjects that on the top that actually had very little change in oxygen saturation with exercise. These were asthmatics exercised to exhaustion. And we had, the PO2 didn't go down, if anything it trended upwards, but we had subjects that did desaturate and developed significant hypoxemia during the exercise. So in this particular study they were divided up into the sort of two groups, but you can see that there's sort of overlap. And you have some asthmatics then that will definitely develop desaturation and hypoxemia, and others that will not during exercise. Now, why would they develop hypoxemia during exercise? This is an illustration of the distribution of gas, in this case hyperpolarized helium, which allows you to image by MRI and shows you a nice homogeneous distribution of gas within the healthy lung. This is an asthmatic that had an FEV1 which was 67% predicted, so there was significant obstruction, and the FEV1 FVC ratio 65%. But you can see these dramatic abnormalities in ventilation distribution within the lung. And of course, even when the spirometry is quite good, you can find that there are these ventilatory defects within the lung of asthmatics, which we of course have no convenient way of measuring. If we could measure these things, we would be more struck by the abnormality than we are on the basis of the FEV1. So of course, if an individual exercises, the impact of these areas that are underventilated will actually become even greater. And there may be other areas that will participate in this phenomenon of low ventilation perfusion ratios. Now, the theories as to how all this comes about have sort of oscillated between two major groups that have kept the argument alive for quite some time. One is that there are changes in temperature within the airway, and this was a very early study done by McFadden and colleagues where they put a bronchoscope down the airway and they measured the airway stream temperature. And what we're looking at here is the glottis. So this is the distance from the nose down into the lung. But here we have the glottis shown by the arrow, and then we have the main carina here. We have right lower lobe and segmental and subsegmental airways. And what these curves are they're showing us the temperature at different levels of ventilation. So if we look, for example, at 100 liters per minute, the temperature of the at the level of the glottis is about, in this case, 29 Celsius. So that this was room air at 26 degrees with a reasonable amount of water content. So in fact, even if the air is not that cold, when you start to ventilate at high levels, you will cool the airstream and cool the airways significantly. And the reason for that is because you actually lose water by evaporation from the airway surface, and the loss of water is the evaporative heat loss is what causes the cooling. Now, of course, if you do the same thing with cold air, in this case it's minus 18 Celsius and no water content whatever, so very dry, very cold air. And this is showing us temperatures at the carina as a function of ventilation. So in fact, at the carina you could have a temperature that is as low as 23 Celsius on inspiration. So dry air, and particularly cold dry air, can reduce airstream temperatures very, very dramatically. Now, what are the consequences? Well, first of all, as I mentioned, the airway temperature falls, and the more you ventilate, so the greater the exercise, the farther the fall in temperature will penetrate into the lungs. This results in the release of biochemical mediators, and it's still argued as to which particular cells produce all of the mediators that are important, but we do know that mast cells are activated by this phenomenon. The airways then, of course, react to these mediators, giving us the bronchospasm associated with exercise. And as I mentioned, there were the two major theories. I've just told you about the temperature changes, and the other one relates to the possibility that there's engorgement of the airways by blood. And it's certainly known that if you look at the blood flow, this is blood flow within the mucosa of the airways in normal subjects versus asthmatics, the blood flow is greater in the airway mucosa of the asthmatics. Perhaps not surprising because there's inflammation. We also know that there's vasculogenesis. There's an increase in the number of blood vessels within the mucosa of the asthmatic. Also, the temperature of the expired air is warmer than in the healthy control subjects. So the idea is then that if you cool the airway, this actually increases the blood flow in the airway. So bronchial blood flow is curious and is different from systemic blood flow. If you cool the skin, you will get vasoconstriction. If you cool the airway, you will get vasodilation. And the idea is that perhaps you get an increase in blood volume within the airways that encroaches on the airway and causes problems. I think the idea that cooling the airways triggers the response is, to me, more attractive, but it's still a little bit debated. Now, the people who argued that it was a temperature change have actually tried to argue that there might be a change in osmolarity through evaporation from the airway lining fluid, and that this change in osmolarity, rather than change in temperature per se, is triggering the reaction. But in fact, it's not been possible to show any differences at different levels of ventilation here. Measuring the osmolarity of the lining fluid of the airways, it seems to be fairly stable. So whatever evaporation you get from the airways seems to be compensated for by an increase in blood flow and secretion of fluid into the airway. Now, we know that Cysteinyl leukotrienes are actually involved in exercise-induced bronchoconstriction, and not mentioned earlier that they have a role in viral exacerbations, but they're certainly well documented to be involved here. And this shows you that in the sputum of subjects that have exercise-induced bronchospasm, you have more leukotriene measurable than you do in those that do not have exercise-induced bronchospasm. And there's a relationship actually between the number of epithelial cells within the airways that are shed. So you have epithelial damage and shedding of the cells in proportion to the amount of cysteinyl leukotriene that is present. Now, how do we diagnose exercise-induced asthma? Well, usually the recommended test is to try and trigger it with exercise. So high-intensity exercise is required for this, and preferably with air that is not too warm and not too humid. You can also do eukapnic voluntary hyperventilation, breathing dry air, and devices are sold for this purpose, and one can also try and trigger the bronchospasm simply with the stimulus of ventilation. Mannitol challenge has been approved by the International Olympic Committee as a surrogate for exercise provocation. And of course you could also do methacholine challenge to see whether the individual has reactive airways to methacholine. Now the agreement, however, between these different tests is not that great, and this is the percent fall in FEV1 with mannitol versus the fall with methacholine, and it's a little bit all over the shop. So even though there's a rough agreement, the agreement is only about 69% between mannitol and methacholine. It's only 62% between mannitol and exercise challenge, and 63% between exercise and methacholine. So all of these tests have their problems of sensitivity and specificity. But if you do an exercise challenge and the FEV1 falls by greater than 10% in the 15 or 20 minutes, 30 minutes after exercise, then you can consider that a positive test and proceed clinically on the basis of that. In reality, if individuals have symptoms, we proceed on the basis of the symptoms and do therapeutic trials. Is exercise good for asthmatics? You could argue that it might be, maybe yes, no, maybe, it depends. So it does depend, in fact. Obviously, in individuals that have exercise-induced bronchospasm, you'd consider that to be bad. But in fact, exercise challenge does not induce airway eosinophilia, even if you induce the same degree of bronchospasm with that as you do with, let's say, a methacholine challenge. If you measure if you do an allergen challenge, I should say, and you measure the eosinophils in the sputum, you'll find them elevated. But if you do a comparable exercise challenge, you will not get any increase in eosinophils. There is a little increase in neutrophils, and that the significance of that is uncertain. So you don't get typical asthmatic inflammation. In fact, there are some experiments using mice where they challenge them with an allergen, ovalbumin, and if you pre-exercise the animals for a couple of weeks before you challenge them with the allergen, you can attenuate the inflammation, and you can actually, happens without attenuating total IgE, but you do actually reduce specific IgE. So in these animals, the corticosterone levels rise sufficiently to give you a therapeutic effect. But it's not clear that this actually works in humans. There are some special circumstances where the exercise can be adverse. For example, in swimmers, there is a very high prevalence. These are elite swimmers. There's a high prevalence of methacholine hyperresponsiveness. So these are healthy controls. And the swimmers down here that are these elite athletes are comparable to asthmatics in terms of their methacholine responsiveness. And this is also true of cold air athletes, although not quite as much as the swimmers. And the swimmers also have a lot of bronchial epithelial cells that are shed. So it appears that particular form of exercise may be somewhat more damaging than others. And the reason it is thought is because of the use swimming, in fact, in chlorinated pools, which creates an increase in neutrophils and an increase in eosinophils in these subjects. Just the last point, there is some evidence, however, that swimming training, not necessarily elite athletes that might spend 5 or 6 hours a day in the pool, but swimming training does in fact improve the VO2 max of children. It will improve their physical work capacity and their lactic acid threshold, so their fitness as measured in that way improve. It's debatable in adults whether this works. This was a study that was reportedly positive for adult asthmatics. However, there was a Cochrane review that didn't actually agree with that and couldn't find strong evidence in favor of improved asthma control. So I'm not talking about simply being fitter, but whether your asthma is benefited. I'll finish in 45 seconds, sorry. Treatment is pretty much like all asthma, in fact, but there's perhaps a particular role for anti-leukotrienes in the treatment. Short-acting beta agonists are extremely useful. Single administrations of a long-acting beta agonist would also work, but if you use long-acting beta agonists on a regular basis, you will lose the protective effect, the prophylactic effect of the beta agonist on the exercise-induced bronchospasm. Inhaled steroids will also improve the situation, and in fact, pretty much all of the asthma medications have been useful. So short-acting beta agonists are excellent to protect. All therapies have some efficacy. Regular beta agonist use worsens exercise-induced asthma and leads to desensitization and tolerance, and therefore one has to be careful to avoid that. This just shows us that montelukast will attenuate the post-exercise bronchospasm. And I'll stop there since I've run out of time, and maybe we can deal with these issues in the question.
If you said 45 seconds, you still have 5 seconds.
Oh, I do, okay. So just the conclusions are that exercise is associated with increased airway narrowing in many asthmatics. Bronchoconstriction may occur after exercise, which is classic exercise-induced asthma, but it can also develop during exercise. Cooling of the airways is likely to be the trigger. High-level sports, swimming in particular, may predispose to inflammation of the airways. This is really excessive exercise, you might consider. Exercise, however, in moderation will improve aerobic capacity in asthmatics, and the treatment certainly does need to be individualized. So thank you very much.
Dr. Hamzawi and Dr. James, thank you very much for the interesting, informative, and clearly stated conferences, and right on time. I think we still have 10 minutes till 6:30, so we open the floor for questions and answers.
Je veux vous poser la question, s'il vous plaît, suivante. Vous avez dit que les utilisations des antibiotiques chez les enfants peuvent aggraver le tableau d'une infection, plutôt d'un asthme. Et on sait très bien que les asthmatiques, surtout chez les enfants, font des infections à répétition. Première question, quel est où on peut donner les antibiotiques? Devant n'importe quelle fièvre, on peut donner des antibiotiques ou non? Et deuxième question, si l'enfant déjà a été traité par les antipyrétiques à répétition et la température reste telle qu'elle est, où on peut donner les antibiotiques?
Merci beaucoup.
Non, il y a encore 2 questions, s'il vous plaît. D'accord, j'attends votre réponse première.
D'accord, merci. Les antibiotiques sont des marqueurs, en fait, de la fréquence des infections. Ce ne sont pas eux qui déclenchent l'asthme, ni qui déclenchent la crise. Simplement, ils ont été utilisés comme marqueurs. Plus on a besoin, plus les médecins prescrivent d'antibiotiques, plus ça veut dire qu'on a fait des infections respiratoires. Maintenant, jusqu'à très récemment, on considérait que chez les enfants, ce qui déclenchait les crises, ça n'était que les virus. Donc, du coup, on n'a pas mis d'antibiotiques du tout pendant très longtemps. Je crois que ça continue à être la règle parce que les enfants qui font des crises d'asthme, le plus souvent, c'est viral et il n'y a pas besoin d'antibiotiques. Même si ça dure une semaine, en général, une virose, ça dure une semaine. Maintenant, est-ce qu'il va falloir chercher des bactéries chez des enfants chez qui les symptômes persistent plus longtemps, les enfants qui sifflent sans arrêt, que vous n'arrivez pas à améliorer malgré le traitement? Là, la question est oui, mais la question est, il faut aller les chercher de façon agressive, c'est-à-dire il va falloir faire des endoscopies, et on ne sait pas encore si, quand on trouve un germe, quelle est la durée du traitement. Probablement, il va falloir faire un traitement relativement prolongé pour nettoyer.
Any other questions? We have 5 minutes more, so you'll have your turn after that.
Dr. Martin, asthma and sports. For people who are making exercise 3 times a week or 4 times a week, do you put them on a regular treatment for asthma and plus just before sport? Or what do you? This is a very practical.
Yes. So my approach is if the person exercises not very regularly, then I think short-acting beta agonist is the treatment of choice. If they have perfectly normal airway function in between those episodes. Many of them actually have asthma through other triggers, and if you measure spirometry, it's not normal, and therefore I treat them on a regular basis. But for the isolated cases, PRN, beta agonist before exercise is okay. If the person is exercising 3 times a week, I consider that excessive use of beta agonist to use it only. Therefore, I prescribe inhaled corticosteroids. And if they are not sufficient, I then just treat as regular asthma. Yeah. And then sometimes I'll give an inhaled corticosteroid, and if the protection isn't sufficient, I may try an anti-leukotriene in combination and see if that does it.
Dr. Hon.
My question is, what about exercise-induced asthma in persistent asthmatic people, very well treated, but they have always exercise-induced asthma, even in full treatment of their asthma and documented by pulmonary function test? What we can do in this case? They are fully treated with all medication, but they couldn't do their exercise or effort. Do you have this kind of people?
Yes, so, I mean, there are occasionally individuals that will still have exercise-induced symptoms. Do you mean after exercise or during exercise? During exercise, yeah. That's right. So they cannot exercise. That's correct. So, I mean, you can only give the maximum amount of treatment, and then you're sort of stuck. The problem with when we use a combination of long-acting beta agonists and steroids, the regular use of long-acting beta agonists loses its protection against the exercise-induced symptoms. So I make sure that I try anti-leukotrienes in all those individuals. If it doesn't work, it doesn't work. I mean, they have to live within their limits. If their asthma is bad enough in other ways and they have exacerbations repeatedly, then we can consider anti-IgE therapy. But I haven't seen any studies looking at the effects of anti-IgE on exercise-induced bronchospasm, to be honest.
Next.
Excuse me. For a patient who's not asthmatic and they have some induced episode of asthma and during exercise, this kind of people, did you treat before doing exercise or no? Did you give any treatment or no?
Yes, so I just recommend a short-acting salbutamol before exercise, because salbutamol, even if you're taking it regularly and it causes some degree of desensitization, if you take it right before exercise, it's still protective. So it's a good choice. So salbutamol before exercise, 15 or 20 minutes beforehand, is a good way to inhibit the exercise-induced bronchospasm.
It's for non-asthmatic usually people,
well,
yes?
Yeah, you can argue if this is asthma or this is not asthma, but for somebody who just has this very isolated event, that's the recommendation. Yeah.
Pour Agnès, est-ce que le CBC peut apporter quelque chose dans le diagnostic bactériologique après des séances de kiné, ou est-ce qu'il faut passer directement à la fibro qui reste un examen invasif?
Il n'y a pas vraiment de preuves. Mais disons que dans les études, souvent le CBC n'est ni sensible ni spécifique. Et on peut passer à côté de germes. Donc la recommandation, c'est quand tu as vraiment un enfant qui est très symptomatique, il faut aller à l'endoscopie. Qui n'est pas un geste si agressif que ça finalement chez les enfants. Ils ont tendance à bien tolérer ça.
Agnès, merci pour cet exposé très complet. Juste une petite remarque par rapport au reflux, parce que ça c'est casse-tête des fois, le reflux gastro-œsophagien qui revient, et c'est vrai que dans les études là on n'a pas vu le sujet abordé, et deuxièmement c'est pas le problème, je pense, j'allais dire en France, au Liban ni en Tunisie, peut-être la sensibilisation par rapport aux aliments dès la naissance aussi. C'est la théorie TH1, TH2, etc. En deux mots, bien entendu.
Oui, alors par rapport au reflux, c'est toujours la question, mais finalement, on a tendance à surestimer l'impact du reflux. Le reflux, ça fait tousser, ça fait des fausses routes, mais ça ne fait pas franchement siffler. Et il vaut mieux, à mon sens, et je pense que c'est le sens des études, il vaut mieux commencer par traiter l'asthme, et si ça ne marche pas, aller chercher un reflux et traiter le reflux plutôt que faire l'inverse, parce que quasiment tous les enfants qui toussent vont avoir un reflux, mais ce n'est pas nécessairement ça la cause du problème. Par rapport à ta deuxième question, c'était sur l'âge d'introduction des aliments. Les recommandations actuelles, c'est à partir de 4 mois, donc utiliser la fenêtre entre 4 et 6 mois pour faire la diversification alimentaire. Et par contre, proposer plutôt l'allaitement maternel le plus longtemps possible, disons au moins 6 à 7 mois. C'est ce qu'on propose. Nous, notre problème sur la diversification alimentaire, c'est d'abord qu'on donne du lait en boîte classique à des tout petits bébés, parce que les gens n'ont pas les moyens de s'acheter du lait en poudre et ils ne suivent pas les recommandations d'allaitement maternel. Et le deuxième problème, je ne sais pas si vous avez la même chose au Liban, nous on a un énorme problème avec les fruits secs qu'on donne très vite aux enfants pour les rendre intelligents. Donc c'est bien dans un sens parce qu'on a très peu d'allergies aux fruits secs, mais l'inconvénient c'est qu'ils font des inhalations de corps étrangers de façon très fréquente et on a donc des soucis avec ça.
Thank you very much. Thank you.